Uh, Friends, good evening. Welcome to this webinar of Indian Society of Critical Care Medicine and Society of Neurocritical Care. It's good to have these two professional organizations coming together, and just like organ crosstalk, we have crosstalk between societies, which is important for collaboration and, of course, improving patient care. So we have a power-packed 60-minute session, and to begin with, I'd like to welcome all the um, faculty out here. So the program will be having initially a lecture on epidemiology of meningitis in India, and then of course a panel discussion on ARDS in brain injury patients. And it's a very unique problem that we often come across in the intensive care unit. And not uncommonly, we do find patients with severe traumatic brain injury having either lung contusion or which can evolve into ARDS, or just severe lung contusion bad enough where ventilation becomes a challenge. So before much ado, I think I welcome the chairpersons for the first talk, Dr. Saurav Bhargav and Dr. Vinay Singhal. They will be actually chairing the session. So over to you, Dr. Saurav and Dr. Vinay.
Thanks, Dr. Sunil, and it's my pleasure to invite Dr. Harish for the talk. And Dr. Harish is the consultant and academic in charge at your critical care medicine at Narayana Hartale at Bangalore, and he will be talking on the this very unique problem which we see very regularly, but having a very different etiology in various age groups and patients with the different backgrounds. And we'd like to listen. So without wasting much time, welcome, Dr. Harish. Saurav has joined, I think.
Good evening, all. So, should we start now?
Yes, Dr. Harish.
Yes. I think there was a loss of voice in between.
Just move your slide just to make sure it's working. That's all. Yeah. Good. Yes.
Good evening, all. Good evening. We'll try to understand the epidemiology of meningitis in Indian scenario. So the data is very sparse, particularly in relation to age group and that of the organism specific and the clinical profile, general category, immunocompromised. I'll try to put all these things in 15 to 20 minutes in the coming slides. So why we need to understand the epidemiology, what is its important? So if you see, it's having a huge national burden. Like in 2019, India recorded around 552,000 of meningitis cases with around 35,000 deaths. So which underscoring a substantial disease burden in the Indian context. So again, if you see the global pediatric impact, so children under age of 5 remain the most vulnerable category globally. So around 1.28 million incident cases and around 112,000 deaths in 2019. So this was the 5 years data, 5 year back data. So the data is always underestimation of meningococcal disease. So meningococcal meningitis in India faces a significant underreporting and surveillance gaps. So reliable data are scarce due to limited lab capacity, misdiagnosis and widespread antibiotic usage. So yet outbreaks, especially those driven by serogroup A, have been documented, and other serogroups like B, C, W and Y are increasingly reported. So when comes to Indian data, as I already told, there is a varied etiology across the region. So across Indian studies, strep pneumonia is the predominant pathogen. So with reported prevalence ranging from 4 to 61.8%. So this highlights, so there is a huge regional difference and the complexity of causative agents. So that is a problem in Indian scenario when it comes to pooling up of the data. So lots of varied like publication, varied evidence is going to appear. So we'll take you through some of the published data which is available in terms of the epidemiological studies. So this was almost a decade back data in 2012. So which is like epidemiological study of acute bacterial meningitis in admitted children below 12 years of age in one of the teaching hospital in Pune. So 79 suspected cases of meningitis. So like around 75% were under 5 years of age. So the case fatality rate was around 14%. Interestingly, they were not able to find any significant correlation between age and mortality and gender and that of the mortality. So they published 16 cases were confirmed bacteriological meningitis. So obviously, like they have noticed, so Klebsiella pneumonia in around 30%, Neisseria, Haemophilus influenza and strep pneumonia were not isolated in any of the cases. So this was some sort of the data which put some sort of conflict or contradict to what we understood. Okay, strep pneumonia is the most common cause for the meningitis, but it is a single institute data. But later, so in like somewhere 2018, we got this very good data published. So burden of bacterial meningitis in India. So it's a preliminary data from a hospital-based sentinel surveillance network. What they have done, so they pulled the data between 2012 and 2013. So with the age group somewhere between 1 year to 5 years of the age group. So around 3,000 odd suspected meningitis cases were enrolled. So among 19,670 children who got admitted during that period. So in that, so 257 cases were confirmed as cases of meningitis. So again, as we expected, the data came out. Strep pneumonia was around 83%. Haemophilus influenza type B was around 15%. Neisseria was around 3%. So highest prevalence was observed in the age group between 1 to 11 months. So most of the data, as I told, it is available in the pediatric age group. So antimicrobial susceptibility test revealed considerable resistance among strep pneumonia. So particularly commonly used antibiotic like cotrimoxazole, erythromycin, penicillin, and that of the cefotaxime. So when they like looked into serotype of strep pneumonia, so the commonly prevalent serotypes in the circulation included 6B, 14, 6A, and that of the 19F. So more than 90% of the serotypes identified were covered by pneumococcal conjugate vaccine. See, the epidemiology, the prevalence of strep pneumonia meningitis had a drastic change. So prior to pneumococcal like conjugate vaccine versus that of the post pneumococcal conjugate vaccine. So they observed that strep pneumonia was the commonest cause of bacterial meningitis in hospitalized patient under 5 years of age. So continued surveillance is needed so that we can adopt pneumococcal conjugate vaccine in the universal immunization program. So that was the inference. Again, this was the data from that of the 2018. So this is the data, as I told. So most common organism they identified was strep pneumonia, next was Haemophilus, and that of the Neisseria meningitis. If you see the resistance pattern, so none of the organisms were sensitive to cotrimoxazole. So then like around 62% susceptibility for erythromycin. So cefotaxime is around 93%, penicillin is around 86%. So among the strep pneumonia cases. So again in 2021, one more epidemiological data we got. So this is the meningococcal disease burden in Indian scenario. So this is one of the systematic review and meta-analysis which got published in 2021. So the result of this data, particularly they looked into Neisseria meningitis, that is meningococcal meningitis in epidemic and endemic condition. So was around 12% prevalence. So in the epidemic and endemic was around 0.76% prevalence. So with a case fatality rate of around 13% in epidemic setting. So Neisseria meningitis caused around 3.2% of acute bacterial meningitis, overall bacterial meningitis in the endemic setting. So the disease appeared in infant, adolescent, and adult with subgroup A prevalence as the highest prevalence. So this suggests like the mortality case fatality rate was very high with the Neisseria meningitis, even though it is one of the third common cause for the meningitis in Indian scenario. So in India, so Neisseria meningitis is the third most common cause of acute bacterial meningitis in age less than 5 years and account for an estimated of around 2% of all acute bacterial meningitis regardless of the age. So it remains endemic in India with a major outbreak reported in Delhi, so Meghalaya and Tripura over the last 25 years. So 12 serotypes of Neisseria meningitis have been identified, of which 6 ABCWXY so have been isolated so as the major cause for the outbreak. So data show that so the number of cases reported for meningococcal meningitis have increased around 40%. So in 2005 to the initial data was around 3,400 cases to 5,609 cases by 2012. So though there is a significant increase in the cases, so the case fatality rate is slowly decreasing with the advanced identification, advanced isolation technology, and advanced therapeutic and chemoprophylaxis. And also even National Center for Disease Control advised a combination therapy for antimicrobial therapy and supportive therapy for meningococcal meningitis. Also, it advised chemoprophylaxis for those in close contact and that of the susceptible population. So with all these advancements, so there is a decrease in the case fatality rate, though there is an increase in the prevalence and all. So according to again Global Meningococcal Initiative meeting held in India, so actual incidence of this disease is not reliably known due to suboptimal surveillance and insufficient diagnostic support. So this is one of the major problem in India. So the conventional culture techniques are used for diagnosis, which are often incapable of isolating Neisseria meningitis on a common routine practice. So non-culture based methods such as PCR have a limited availability in the tier 2 cities and all. So this result in underrepresentation of the true burden of the disease. So vaccination is the best preventive modality. So however, in India, so meningococcal vaccines are recommended either for high risk group of patient or during an outbreak or epidemic situation. So this is the inference from one of the data which published, which gives a many input into the meningococcal meningitis. So one more data. So in 2021, so this is the data they collected somewhere between 2012 to 2016. So basically, so they included around 12,940 patients. So 586 were lab confirmed strep pneumoniae, which was the most common detected organism. So next is Haemophilus influenza and next is the Neisseria meningitis. So overall around 58% confirmed bacterial meningitis cases were in children aged between 1 and 11 months. Haemophilus influenza is having a highest case fatality rate. So this is the data, huge data, which got published almost 3-4 years back in 2021. If you see, so these are the institutes which are included in this published data. So Shimla, so many of the very good high-end quaternary referral centers has been included in this data. So as I told, so most common pathogen among all the age group was strep pneumoniae, so which is even irrespective of adolescent, young child or neonates, or in that of the elderly also. So with the Haemophilus influenza, according to the data, is having a highest case fatality rate. So again, they looked into strep pneumonia susceptibility. So there was none of the organism are susceptible to cotrimoxazole, and vancomycin retained a very good susceptibility for the strep pneumonia, almost 100%. This is the very recent data. So again, 2021. So this is one of the systematic literature review on the prevalence and etiology of meningitis among critically ill hospitalized patients in India. So 38 studies. So this is one data which included all age categories, so all comorbidities, including immunocompromised patients and all. So which suggested again, so among immunocompromised, we have a cryptococcal meningitis is the most common among HIV and AIDS patient, and strep pneumonia found to be the predominant pathogen causing meningitis across different regions in India with a frequency ranging from 4 to 60%. So there are a wide range of the difference in terms of the like provided data according to the published data in 2021. So this is very recent. So the India Brain Infection Guidelines Project, so 2024, so which put again all these controversies together. So no doubt there is an increase in burden of the incidence, but there is a decrease in case fatality rate. But they identified, so recent literature report, so increasing case of meningitis and encephalitis due to like tropical infection, particularly scrub typhus, dengue, chikungunya, whereas Japanese encephalitis virus and Haemophilus influenza have become less common. So this is the latest data which we got. So in terms of clinical epidemiology of the meningitis in Indian scenario. So if you put everything, so this is the 2019 huge data. If you see, meningitis estimated cases are like 5,50,000 odd, with the estimated death was around 35,000. Encephalitis around 6,10,000 with a 50,000 mortality rate according to the published data in 2019. So if you see the community acquired bacterial meningitis in children, so this is the data of sentinel surveillance. So with strep pneumoniae is common among the age group of less than 5 years. Next is Haemophilus influenza type B, so less than 5 years. So Neisseria meningitis less than like 5 years, that is the confirmed meningitis, which is the commonest organism, so across this age group. So when it comes to mixed age adults in the tertiary care hospital data, see surprisingly one data which showed increase in incidence of like Klebsiella pneumoniae, so which is like bit more than that of the strep pneumoniae. So this is one tertiary hospital based study. It is not a like combined meta-analysis or systematic review. So there is some burden of Klebsiella pneumonia even in community, that we need to understand. So when it comes to healthcare associated, that is hospital acquired meningitis among the adult patient, so we have coagulase negative staph aureus, so which may be secondary to head injury, so external ventricular drainage or decompression craniectomy on the floor. So we have a burden of coagulase negative staph aureus, so staphylococcal aureus, so then enterobacteriaceae, that is gram negative organisms which we face, so drug resistant Acinetobacter like Klebsiella, Pseudomonas, so that depends upon any particular institute. So that's about the healthcare associated, so meningitis like among the adult patients. Again, this is the data on meningococcal meningitis. So epidemic, like prevalence of Neisseria meningitis among suspected cases around 12%. In endemic area, it is 0.76%. So again, culture confirmed acute bacterial meningitis, it's around 3% in the endemic area with a case fatality rate of around 13%. So hospital acquired neonatal meningitis, okay. So late onset meningitis cases around 85% of neonatal meningitis. So gram negative pathogen is around 73%. So among the gram negatives, Acinetobacter is contributing around 48% with the highest case fatality rate. So among the hospital acquired meningitis, around 40% case fatality rate. So that is among the neonatal meningitis. So what about immunocompromised patient? Okay, so I tried to break down into different categories. So other than the neonate, other than the adult, so one more susceptible category is the immunocompromised patient. So as we are aware, so cryptococcal meningitis, that is a cryptococcal species meningitis, so contributing around 2 to 53% of cases in HIV positive or other immunocompromised patient. So this is the tertiary care studies data. Again, strep pneumoniae remain the commonest, like other general population. Among immunocompromised also, the commonest organism remain the strep pneumoniae. So we have a Listeria monocytogenes, so particularly in extremes of age. Again, we don't have a huge published data on Listeria, but the risk category is extremes of age and that of the immunocompromised patient. So we have other fungal meningitis, okay. Again, global data is available. So Indian data, so which aligns with that of the global data, that is a cryptococcal meningitis. In terms of immunocompromised, so cryptococcal is most prominent among Indian immunocompromised patient, particularly HIV and AIDS, with prevalence of 2 to 50%. Strep pneumonia still remain the commonest among immunocompromised, so like that of the general population. Listeria, we don't have a very good published data, but susceptible are extremes of age, so on that of the immunocompromised patient. So other fungi like Candida and Aspergillosis are rarely reported in Indian immunocompromised patient. So in terms of the like split into type of immunocompromised, like HIV positive patient, cryptococcal, so AIDS advanced disease like established manifestation of the AIDS, again cryptococcal. So transplant recipients and other immunosuppressed, so Listeria monocytogenes is reported. Neonates, pregnant, elderly with immunocompromised status, if you consider them as a susceptible, again there are some case reports on the Listeria monocytogenes. Okay, so what about the viral meningitis epidemiology? This is one interesting data, like published. If you see, like it is from the outside of the data, like outside the India. In Indian scenario, we don't have a very good data on viral meningitis, but the global context, around 11 per 1 lakh population, we have an annual report of like viral meningitis. If you see the organisms, so enterovirus, so EBV, adenovirus, others are varicella zoster, and that of the HSV1 and that of the HSV2. So Indian study data is also available, but major data we got from outside India on viral etiology. So this is the fungal etiology, like systematic review and that of the properties among fungal meningitis. So cryptococcal meningitis, so around 11,000 cases annually. This is the like annual incidence in India. So majority are HIV positive. So other like Candida aspergillosis, sporothrix, not specified in Indian data. So mucormycosis, like we have a major problem with the rhinocerebral disease, may not be a typical meningitis. So but if you see all forms of reported cases of rhinocerebral, that is around 2 lakh cases were reported per year. So that is all causes, may not be clear cut meningitis, but it is a rhinocerebral. We know that it is going to like penetrate into the so angio invasion involving the brain parenchyma and all. So to conclude, so community acquired meningitis in children, strep pneumoniae dominates. In adult, there is some data available. Okay, other than strep pneumoniae, we have other organism is Klebsiella pneumoniae. So hospital acquired meningitis, so coagulase negative staph aureus. So other staph aureus and gram negative is the huge burden. So meningococcal disease, rare nationally in endemic period, but causes significant burden of outbreaks. So neonatal setting, hospital acquired meningitis often involve resistant gram-negative pathogen, including Acinetobacter, which is having a high mortality. Thank you.
Thank you, Dr. Harish, for a very lucid your talk on the subject, and very good. You had restricted yourself to epidemiology of your meningitis. And do you see any changes in the epidemiological this thing in last 20 years or so, or because we have very, very less data. Most of the time, your patients are they are either coming very late. Microbiological labs are not available in peripheries where we can make a particular diagnosis, or or patients come with some treatment. Many times these cultures are negative. So, question number one, that do we see any changes in the epidemiological data? And number two, how to improve our your how to obtain the organism, actually culture positivity, how to improve this culture positivity. So
See,
meantime,
basically, yeah.
yeah,
So in terms of epidemiology, one, the published data still is strep pneumonia. So here and there we have some, like as I told, like Klebsiella here and there, but
yeah.
strep pneumonia, Haemophilus, and that of the Neisseria. So this is the chronology hierarchy which is still retained. But in terms of like picking up, we have a multiplex PCRs and all. Maybe down the line in next 5 years, we have a very good data because many of the referral quaternary tertiary care centers started using like the tests like biofire film array. There are many multiplex PCRs are available. So one good thing is even patient received antibiotic. So because these are all like genetic material based test, so definitely the sensitivity is very good and we are able to isolate good number of etiology basis for the meningitis, even though they received antibiotic in a community based hospital. But culture, as we know that like CSF very difficult to grow, so our like the most of the time the clinical practices we are going to see, okay, like sugar cell protein, so then we'll think, okay, this looks like a bacterial or looks like okay partially treated or maybe viral or TB, so then we are going to treat. So many a times we are not able to isolate the organism. But coming days, definitely in our practice also we adopted, okay, like we do multiplex PCR on a routine basis. So many a time, so if we get like negativity on the PCR technology and all, so we are able to cut down, particularly when we start them on an empirical like vancomycin ceftriaxone acyclovir, at least we are able to cut down the acyclovir kind of this one, because it's having its own burden of nephrotoxicity and all.
Yeah. There's a comment from Dr. Shikha. I think with increasing incidence of Klebsiella and Acinetobacter in hospital-acquired meningitis, we can really rely on the RT-PCR for early detection due to limited scope of the panel, which detects only community-acquired meningitis.
Yes, sir. Can I just elaborate on this question?
Yeah, please.
Yeah,
So, most of these, as you said, that multiplex PCR would be very helpful. But again, what we have seen in our area is that when it comes to hospital-acquired meningitis, there is always a suspicion that that could be a Klebsiella or Acinetobacter. You've already mentioned that. And the conventional multiplex PCR, most of them, like we have the BioMurio one, most of them they only have limited scope because they are panel for community acquired meningitis. So PCR for staph is not there, for E. coli, Klebsiella, Acinetobacter is not there. So in that case, I'm not sure if other companies have a community acquired hospital acquired meningitis panel. So what to do in that case? And the second part of the question is that because these bacteria are very difficult to retrieve on standard culture, and we know that traditionally the treatment for hospital acquired meningitis has been carbapenem or cefepime or plus minus vanco. Now, but considering that we have a lot of carbapenem resistance in hospital acquired infections, so what should be the standard of empirical therapy? Should we start with some kind of colistin straight away? Because of course, this kind of meningitis is also not going to give you a lot of time. It is going to be very catastrophic. So what would be the empirical drug choice for hospital acquired meningitis?
See, basically, your first question, see, there are
Mm-hmm.
commercially available multiplex PCRs. They elaborated and extended their panel. So, like
Okay.
the Exciton infection is there. So, Rivara Labs, so they have come up with like gram-negative organism included in their panel. One more thing, what you can do is like the same biofire film array. What we practice is you send it as a blood panel, like blood panel that include gram-negative organism, or you can send or do or process the sample of the CSF as a lower respiratory panel. In biofire film array, we have one upper respiratory panel, lower respiratory panel. So lower respiratory panel, particularly they meant it for VAP. So sometimes it at least help in isolating an organism, even though it is not very well validated, but it is based on genetic material. So you can process the sample like that. But there are commercially available like a multiplex PCRs which taken into consideration of the wide array of the gram negatives also. When it comes to therapy, so basically we know that what it mimics
Dr. Harish, I think keep it a little brief. We can go on. We need to go to the next
So
one as well.
therapy, your risk profile always according to like what you isolated in the blood, or maybe respiratory secretion that always mimics in the CSF. If you really bothered about the nosocomial meningitis, so then option is to cover carbapenem resistant enterobacteriaceae group of organisms.
Sure.
Thank you.
Thank you, Dr. Harish. I'm sure there's still lots of questions. We'll try to finish the program and see if we have time for more questions. I think I'd like to thank Dr. Vinay, Dr. Harish, and Dr. Saurav for participating in this lecture. Let's move on to the next topic, which is equally sort of important and interesting as well, a panel discussion. It will be led by Dr. S. Javeri, who is going to be the moderator. And I request Dr. S. Javeri to introduce the panelists and proceed with the panel, please. Thank you.
Thank you, Dr. Sunil. What we are going to discuss today is ARDS in brain injury patients. And to discuss this important topic, we have a very, very important panel. Dr. Arpan Chakravarti. Dr. Arpan Chakravarti needs no introduction. He is leading ECMO program at Apollo Kolkata, and he is a leader for ECMO services countrywide. Dr. Deep Sen Gupta. Dr. Deep Sen Gupta is at AIG Hyderabad, a very young and enthusiastic intensivist. And Dr. Satya. Dr. Satya is intensivist at Rela Institute. in Chennai. We also have Dr. Manoj Singh in our panel. Probably he's stuck somewhere and might take some more time to join. So I'll start the question straight away. My first question will be Dr. Deep Singh Gupta. What is the epidemiology of ARDS in brain injury patients? Not necessarily traumatic brain injury, any brain injury patient.
Good evening, sir. Thank you for your kind introduction, and I take this opportunity to thank you for giving me this wonderful opportunity in this panel. Sir, so the epidemiology, it varies in literature. The different studies have quoted different numbers. To put it across, it varies between 17% to around 30 to 35% overall. And it varies between so brain injury can be because of traumatic brain injury, it can be because of subarachnoid hemorrhage, it can be because of other reasons, and different conditions have different rates of prevalence reported with ARDS.
Yeah. Thank you, Dr. Deep. So 17 to 20%, even 25%, and all traumatic brain injury patients are at risk for ARDS. So all traumatic brain injury patients should be given a lung protective ventilation regardless they have ARDS or they do not have ARDS. My second question is to Dr. Arpan. What are the pathophysiological considerations which vary from a routine ARDS patient to a patient with traumatic brain injury and ARDS?
See, there are multiple reasons why these brain injury patients land up in ARDS. Obviously, the first to contribute is the concomitant injury. With the brain injury, you can have the chest injuries also. So this is probably a pulmonary contusion is contributing to you. Second one is it's an idea of this SIRS following a severe traumatic brain injury, which can lead to a kind of pulmonary kind of inflammation, which can lead to an ARDS kind of situations. Third one is if you see these kind of patients are very much prone as they have lost their consciousness, they're prone to aspirations, the aspiration pneumonias. So these are various forms of the aspiration from the starting, or he has aspirated after 2 days, he got on ventilator, he's on kind of ventilator associated pneumonias. You can get it. So these kind of secondary infections or aspirations, these lead to havoc kind of thing in this kind of patients. Third, fourth one, if we see, we can have another thing is a neurogenic pulmonary edema, which is the pathophysiology is not very much clear. These kind of patients, they tend to react to a kind of pulmonary edema kind of situations where the extrapulmonary areas, the tissues are full of fluids, and you can see these kind of brain injury patients have a very bad lung. So I think this contributes mainly to the main cohort of the ARDS patients. Apart from some fat embolism, some kind of contusions further, some massive transfusions in these kind of patients can lead to somewhat more in the ARDS.
Thank you. So we must differentiate ARDS from aspiration pneumonia and trali and other entities which can lead to respiratory failure. And these entities do ARDS. We have to remember this also. A lung contusion can ARDS gradually. So in the beginning, we must differentiate whether it's a neurogenic pulmonary edema or it is ARDS or it is aspiration pneumonia. And all these entities by themselves can also be a causative factor for ARDS and traumatic brain injury. The key considerations we should always keep in mind which differentiates ARDS in a traumatic brain injury patient. Hypoxemia can worsen secondary brain injury. We must prevent it. Hypercapnia, which is generally allowed in ARDS, can raise intracranial pressure, again a major consideration. Positive pressure ventilation may reduce venous return, especially if it is very high PEEP, and increase ICP. And sedation and intubation, especially at times we require in NIV patient or for head injury patient also we do, can further blunt the airway reflexes and risk aspiration. I will move on to Dr. Satya. What are the gas exchange targets in a patient with traumatic brain injury and ARDS?
Yeah. Good evening, sir. Good evening, everybody. So coming to the gas exchange targets in ARDS, in a neuro ARDS patient, it's somewhat different from the general ARDS patients, that we should understand. Whereas in general ARDS patients, we can accept some amount of permissive hypoxemia and permissive hypercapnia, which is the dictum in general patients. Permissive hypoxia and hypercapnia are not acceptable in traumatic brain injury, given the oxygen needs of the brain. So when it comes to oxygen, we would want to maintain an SpO2 of 90, more than or equal to 90, and which translates to a PaO2 of arterial O2 of around more than 80, at least is what we want to have in neuro ARDS patients. And obviously, ultra permissive hypoxia or even ultra permissive hypoxemia was not associated with great outcomes even in normal patients. So forget that. Even normal acceptable hypoxemia is not something which is acceptable in neuro ARDS patients. And when it comes to hypercapnia, again, we would want to maintain normocapnia in any patient with neurology, acute brain injury. So the targets would be somewhere between 35 and 40. And those with cerebral edema, we would be even more tighter on our targets, say somewhere between 35 and 38. So that's what the targets would be for neuro ARDS patients.
Will you target hyperoxia at any time in a traumatic brain injury patient with ARDS?
No, absolutely no, sir. Hyperoxia is not associated with any benefits. It's actually catastrophic for the patient. It has not got any advantage. So, though they have not done studies to prove all this, but it goes with the same principle for any other patient with ARDS.
Absolutely. So hypoxia and hyperoxia both have to be avoided. Always normal physiological targets. Supraphysiological targets have never worked, neither in ARDS, neither in traumatic brain injury. We move on to the next question. If oxygen is required, we supplement oxygen. In mild ARDS, we often resort to NIV or HFNC. Dr. Arpan, what is the differentiating factor for NIV and HFNC in a traumatic brain injury ARDS patient?
If both the HFNC and NIV requires a good sensorium to start with, and if you have a bad sensorium, so NIV is out of question, or the HFNC is out of question. So in a severe ARDS, when you are find this kind of patients with a traumatic brain injury, not very much evidence is there in a patient who is not having that kind of sensorium and you're giving NIV and HFNC. So I'll not recommend that kind of thing in any kind of cases.
Yeah. So NIV and HFI threshold for intubation should be much lesser in a patient with traumatic brain injury and ARDS as compared to non-traumatic brain injury patient, especially if the GCS is little poor, even 10 to 11, and patient has ARDS, we should better intubate in time rather than
GTD patients,
GTD patients. As in normal patients, if we delay intubation, the outcomes are bad. Same apply to a traumatic brain injury patient also. Dr. Deep Gupta.
Yes, sir.
What are the mechanical ventilation strategies for a traumatic brain injury patient with ARDS?
So, sir, the lung protective ventilation is well established, but that we have to apply with certain changes to the target population of traumatic brain injury. So, in this case, the lung protective ventilation with permissive hypocapnia can be attempted, but with very judicious cerebral neuromonitoring. Brain Trauma Foundation clearly says that both hyperventilation and hypoventilation are detrimental. So, PaCO2 of less than equal to 25 is definitely not recommended. More so, we would target a normocapnia of around 33 to 35, 36 in these patients. Also, we will have to, if possible, and if resources are there, we should monitor the brain tissue oxygen tension as well as jugular venous oxygen saturation to further promote our ventilation strategies. But low tidal volume ventilation with some amount of normocapnia can be attempted in these patients with judicious neuromonitoring, sir.
So, what is the controversy regarding PEEP with raised ICP? Dr. Satya, can you enlighten us on that? Is physiological PEEP like 5 to 6 PEEP is also disastrous for a traumatic brain injury? And what is a safe PEEP for a patient with raised ICP?
I mean, there has been various trials on PEEP in neuro ARDS patients as well, and there are trials which have used somewhere PEEP between 5 and even 15 centimeters of water. So, I mean, some trials used invasive neuromonitoring. Patients had EVD. Some patients didn't have. So, I mean, not all trials were met with some success. So, I mean, physiologically, the PEEP which is acceptable for traumatic brain injury is somewhere between 8 and 10. Some studies go up to 12. So, 8 to 12 is something which is acceptable. One notion which we have to carry forward is that PEEP is not something which is extremely contraindicated in traumatic brain injury. It's not that you should not be going beyond a PEEP of 5 or 6. Definitely we can go beyond it, provided we are monitoring the cerebral perfusion pressure. We are monitoring either invasively or non-invasively, and make sure that the CPP is maintained at all levels. So what we are worried about in PEEP is raised intrathoracic pressure, decreased cerebral venous flow. All that is what we are worried about. So if you are monitoring that, and provided your ICP is not going up, you can do PEEP, increase PEEP at graded intervals. Always you can do that. So, and it is not shown that, many studies have not shown that by increasing the PEEP, it adds up to the mortality, it adds up to the brain injury being aggravated. That has not been shown. So always we can safely use PEEP as used in non-neuro ARDS patients, in neuro ARDS as well.
We must remember hypoxia is a major killer than PEEP for a traumatic brain injury ARDS patient. And as per the waterfall effect, what we understand physiologically, if PEEP and CVP are lower than ICP, they don't influence the effective downstream pressure. If the PEEP and CVP are too high, then it can further compromise the CPP. So we must be having some sort of CPP monitoring while we cater to this patient, or a transcranial Doppler, something non-invasive. Now we give PEEP, still our patient is not able to maintain saturation. We think about proning always. Dr. Arpan, what are the challenges in proning such patients with traumatic brain injury, and how comfortable are we in proning such patients?
See, for the proning thing, in our practice, we categorize patients. Like there is a tiring of the patients, like tier 1, tier 2, where how much is the unstable is the ICP or not. If you have an unstable ICP, unstable brain injury, proning is out of questions then. But if he's having a stable ICP and the RDS is not getting better with your ventilatory strategies, increasing PEEP to 12, 14, so then you have to take the proning pathway. Now, you have to measure your ICP on a continuous basis, whatever way you want. Like some people do measure the ONSD at a regular level. Some, as you are telling me, transcranial Doppler, whatever the way you are measuring, kind of idea of ICP, the neuropupillary diameter, whatever you are using. So that is the thing. If it's a stable ICP and you have a worsening ARDS, there is no contraindication of proning. But after proning, you have to assess whether there is an ICP is going down, or is your patient's brain is not doing well. So this crosstalk has to be always in your mind, like not in the other ARDS patients. So prone with a caution.
Absolutely, very rightly pointed out. So we have to be very, very cautious while we prone such patients, and we have to take care of the jugular venous outflow drainage, more so in the prone position rather than in. And in case there is some cervical spine instability, then again we have to be much more careful.
This is another important point. This cervical spine has to be there.
Yeah. Thank you, Dr. Arpan. We move on to the next question. Patients who require intubation for ARDS, or otherwise also post-intubation, they might require sedation, analgesia, and paralysis. Dr. Deep Sen, how different is your clinical practice in sedating, analgesia, and paralysis for these patients compared to the routine ARDS patient?
So, sir, in our ICU, we now more focusing on analgo sedation concept more than pseudo-analgesia. We are taking care of the analgesia part predominantly, followed by the sedation. Paralysis, sir, is a case-to-case basis decision. For if the patient is having very low PF ratios and lot of ventilator dysynchrony, then we do go for paralysis. Continuous intravenous infusions of cisatracurium we use with neuromonitoring with TOF and all, and but that is on a very short period of time, and as long as it serves the purpose. Mostly we'll go for the analgo sedation with IV fentanyl or dexmed infusion. We add it with some sedative, but then our protocol is to have a daily sedation wake-up protocols and shorter amount of sedation, because we have to take care of the post-procedure ICU delirium factors as well, myopathy factors as well. So we use it very judiciously, but we do use, sir.
Especially in the initial phase of traumatic brain injury, when ICP is raised, we have to be a little easy with sedation. We should not be miser. Once the ICP has settled and patient is in improving phase, probably we can downscale the sedation requirement. We have to remember that we have to do neurological examination. We might miss seizures if deeply sedated patients. So we have to be careful about those issues. But this is again a myth, especially for tier 2, tier 3, and smaller ICUs. We have some EICUs also. They have a myth, head injury patient should not be sedated. So these myths should go away. Especially raised ICP sedation is one of the protocol. And difficult ventilation, asynchrony, again, they have to be nicely sedated. We missed one important discussion. I'll move on to Dr. Satya for that. While we intubate patient with traumatic brain injury and ARDS patient, what are the specific considerations we should always keep in mind?
Yeah. So whenever we are intubating these patients, we should make sure that agents raising ICP should be avoided. So the plane of sedation should really be very deep, so that the concerns of ICP is really addressed. So that has to be the thing. And even after the point of intubation, we'll have to make sure that they are properly sedated. The RAS score is maintained at a deeper level, because we are dealing with double jeopardy. We are having an ARDS on one side, we are having a traumatic brain injury on the other side. Our concern is, basically for both traumatic ICP and the lung, it's better that we sedate them generously earlier, use neuromuscular blockade generously earlier. So agents which should raise the ICP should be avoided in the early phases.
Thank you. Another important, a major dispute in critical care all those years, steroids. Dr. Arpan, this must go to you. What is your take on steroids in ARDS in general, very brief, then ARDS with traumatic brain injury and steroids?
Steroids are typically acting on the initial part of the ARDS, inflammatory phase, till the fibrosis develops. So it usually is, but I have not seen much helpful, but people are using it in the initial part of the ARDS. And even then, in a neuro ARDS situations, if you are using its anti-edema measures, you can use it. But probably it is not going to help you in a very bigger way. Sometimes it attracts more infection, it attracts more problems like delay, your sugar control is haywire, your fluid status is going haywire. So these things can happen. So in my take, if we use steroid, the initial part of the ARDS might be sometimes helpful, but not always.
Very rightly pointed out. So steroids are not standard of care for ARDS and TBI, and it still can be justified if it is a steroid responsive condition leading to brain injury like meningitis, autoimmune encephalitis, vasculitis. Otherwise, we tend to avoid steroids in traumatic brain injury and ARDS, unless, as we discussed, those are autoimmune conditions, vasculitis, meningitis. Dr. Sunil Karant, you want to give a comment on this, or our chairperson, Dr. Saurabh, because it's a very important point here.
I think I'll allow Dr. Saurav to first make a comment, and then, of course, I will add in.
On steroids.
As we know, as Dr. Arpan also pointed out, in ARDS, we should be using steroids, if at all, in the early phase. Once the fibrosis has set in, there is no role. But having said that, we know that in traumatic brain injuries, steroids can be more detrimental than of any use. So I do not use any steroids, and I believe there are various studies which point that steroids should not be used in traumatic brain injury unless there are specific reasons. Supposing if you have an optic nerve injury or something where you would like to use pulse therapy, otherwise we don't usually use steroids. And same should be the case in ARDS also.
Dr. Sunil.
Yeah, I think both Arpan and Saurav had already mentioned. I think the role for steroids in ARDS with the TBI, I think the greater harm that we know happens with TBI, I think has to be the priority. And I think ARDS per se will be one of the sort of secondary events that happens with this thing. So I think definitely a big no-no, because we also need to understand that some of these patients go on for quite some time on the ICU, and we will actually predisposing them to a higher risk of secondary nosocomial infections and things like that. So I think no role for certain, yeah.
Thank you. Recruitment maneuver, although they are less practiced in routine ICU ARDS patients also, Dr. Deep, What is your take on recruitment when a patient with TBI ARDS? Any brain injury and ARDS?
So, sir, for any traumatic brain injury, the primary goal is to avoid hypoxemia. And in a situation where there is refractory hypoxemia, which is not responding to any other maneuver, then a judicious approach with recruitment maneuver can be attempted. But again, having said that, usage of specific cerebral oxygenation monitors like SGVO2 or PBTO2 will be more prudent if you're applying recruitment maneuvers, only in cases of refractory hypoxemias. Otherwise, the traditional risk of increasing in ICP and all do remain with recruitment maneuvers.
Yeah. Dr. Satya, you differ or you agree with Dr. Deep on this and Dr. Arpan?
Recruitment maneuvers, even for even for non-neuro ARDS, we're not using that much.
Yeah.
So it should be used very sparingly in neuro ARDS, especially. Is what is my take on that.
I agree, Dr. Arpan. Otherwise, also we are not using much of it unless we are
Recruitment,
stuck to the wall.
Yeah, recruitment.
We lost your voice, Dr. Arpan.
Very high recruitment leading to the loss of venous return is not recommended that way.
Yes. So generally we tend to avoid recruitment maneuvers unless we are stuck to the wall and we do not have ECMO or prone positioning working. So next question and the logical step for a refractory hypoxia is ECMO, and we'll have 3 to 4 minutes at least from Dr. Arpan elaborating ECMO in traumatic brain injury ARDS. Very important topic, and people are hesitant in view of anticoagulation and risk of bleeding. So your take.
So ECMO was in traumatic brain injury. If this webinar had been happened 10 years back, it was a no from me, because it's a contraindication for ECMO initially told. Next, as we have improved our anticoagulation strategy, the ECMO management in the maintenance period, so we have started putting ECMO this kind of patients for different reasons. Because sometimes it has been seen this traumatic brain injury is also associated with a lot of pulmonary contusions, and the traumatic brain injury is not that serious, but the lung injury is that much of serious. And on ECMO, if you give a lung rest, they are coming out within 4 or 5 days, and they are doing better. Now, the question is obviously what should be the anticoagulation strategy in this kind of patients, particularly there is a chance of bleeding inside the brain, and also in patients where their craniotomy has been done. So these two are the main issues. Now, multiple instances we have seen if the patients on ECMO bled inside the brain, and sometimes the neurosurgical colleagues, they don't want to open because there is a fear of the patient will bleed more and we will lose the patient. But as there are some case reports, there are sporadic case reports came in this kind of patients also, you can do a good neurosurgery and the outcome is not that bad. So probably the TBI and ECMO has become a relative contraindication. Now, how we are going to proceed in this kind of cases on ECMO? Obviously, the answer is sometimes the heparin-free ECMO. If you can run a good heparin-free ECMO with a maintenance anticoagulation, with a good flow, you can get rid of this kind of conditions without any much of bleeding. But you have to keep on you have to be watchful regarding your pupillary diameter, at least 2 to 4 hourly, whether there is a ongoing bleeding has started inside the brain or your ICP is rising or not. So this is the thing, you have to be very much careful about your brain condition if you put this kind of patients on ECMO. So the final take is TBI on ECMO is a relative contraindication. Act judiciously if you are regularly doing ECMO.
Thank you, Dr. Arpan. We move on to the next question, Dr. Satya. What are the fluid considerations? What fluid balance will you like to keep in a traumatic brain injury ARDS patient?
Yeah, as with normal non-neuro ARDS patients, a conservative fluid strategy would be better even for neuro ARDS patients. avoiding hypotension at any point of time, and maintaining the CPP at any point of time, we could go ahead with the conservative fluid strategy, as it is shown to be advantageous. And between colloids and crystalloids, again, crystalloids would be the choice if at all we want to give some fluid boluses in the early phases. And as an opinion, I don't think hypertonic saline can be used as a bolus at any point of time, just for the point of giving boluses. Not so. In case we are using it for cerebral edema purpose, we can use it as an infusion as it's usually used. So again, the map targets needs to be individualized as per the person, whether he is used to a higher map or he is used to a lower map. Based on that, we'll have to consider. Maintain, again, having an eye on the CPP at all times.
Thank you. And no hypotonic fluids, no albumin in ARD, traumatic brain injury
Yes,
ARDS. We
yes.
have to be very, very careful with this. What are the procedural risks like bronchoscopy or suctioning, Dr. Deep Sen Gupta, in a patient with TBI, brain injury and ARDS?
So primarily the loss of PEEP, sir. Whenever we do this, that is one, and again the primary goal that hypoxemia should not happen, that may get compromised whenever we're doing a procedure like bronchoscopy or suction. But again, depending on the individual and depending on the indication, this may be mandatory, and that can be done. Then we have to optimize once the procedure is done, and procedure should be as short as possible, and it should be done by an expert as much as possible.
And we have to be careful about rise in ICP during all these laryngoscopy,
Yes,
suctioning,
adequately sedated and if possible paralyzed patient, the procedure should be done.
The last question probably in the discussion, as we have just 2 minutes left now. Tracheostomy, what is the timing? How is the timing different from a non-ARDS patient? I'll put it to Dr. Arpan.
So tracheostomy, probably I will do tracheostomy probably in the second week, because in ARDS if you are not able to take your oxygenation on the correct way, losing the PEEP, losing the oxygenation during tracheostomy is not a good thing in kind of neuro ARDS situation. So probably let it settle down, let it get a control of your FiO2, PO2 ratio, PF ratio, little bit of stable. Then you plan for tracheostomy in this kind of patients, contrary to few neuro patients where we do earlier tracheostomy for the your airway control. So probably in neuro ARDS patient, we will take a later strategy, probably in the early second week, on the second week, after your ARDS thing got settled down.
Yeah. So traumatic brain injury with ARDS, generally it is in the second week, 7 days, 10 days, or might be around within 14 days, as against a routine ARDS, which could be early. We have to remember two things. If we have doubt to tracheostomize or not, better tracheostomize. Do not just extubate and re-intubate. That is even more risky. And another thing is the concern for raised ICP. Do not be in a hurry to do tracheostomy once the disease is not settled. It might be ARDS, as Dr. Arpan pointed out, there will be PEEP loss, or it could be raised ICP because of brain injury. Do not be in a hurry to tracheostomize. So generally 7-10 days within next second week is the right time. The last question I'll put it to Dr. Satya. What is the outcome of these patients and how do you take care of these patients post ICU discharge?
Obviously, there's not been much of data regarding mortality in neuro ARDS. I think, it's 10 to 20% difference between non-neuro ARDS and neuro ARDS. As such, the traumatic brain injury per se is not doesn't have a great impact on ARDS outcomes in these patients. And obviously, recovery will be prolonged in these patients. And since the dual organ jeopardy is there, the ICU stay also will be prolonged. Though we have successfully managed, quite a few patients who had both these issues and were able to come out of these.
Thank you, Dr. Satya. Over to Chairperson and Dr. Sunil. You are mute, Dr. Sunil.
Thank you all. I think it's been a very fantastic 1 hour. Probably we would have loved to have this session extend a little more because lots of sort of dilemma kind of problems, as we saw the ARDS with neuroprotection and good knowledge on meningitis and epidemiology in India. So it's been a pleasure to be welcoming this entire eminent group of doctors and the entire panel of experts. So to end it all, I think there's not much time for any questions. Should we take one or two, or we will
Yeah,
end the
we can take
session?
one or two also.
Yeah, a couple of questions if there's anything on the chat box.
I have a
One
question
question
for
for Dr. Harish, role of dexamethasone. Yes, sir. Dr. Saurabh sir कुछ कह रहे हैं.
Dr. Deep, since ARDS is a prolonged problem, it is not going to get cured in a day or two. So, what is your sedation strategy when it comes to dexmedetomidine? Like, how do you use it? You are muted, Dr. Deep.
Hello. Yes, sir. Sir, so when we initiate the sedation, we go with little stronger sedatives like fentanyl and dexmedetomidine we use towards once the patient is stabilized, PF ratios have improved, and we don't need that deeper level of sedation just to maintain some amount of analgesic sedation. We go towards the later stages of dexmed, sir, not at the earlier stages.
So, in the earlier stages, do you think fentanyl as a single agent is enough, or do you need to add something like midazolam or something else?
We not as a single agent, sir. We use fentanyl in combination most likely with propofol, sir. And if need be, we add a paralyzing agent.
Thank you.
There was a question about dexamethasone, Dr.
Yeah,
Harish
so
managed that.
basically, dexamethasone, so initial data was promising, particularly in preventing long-term neurological sequelae, particularly ototoxicity in strep pneumoniae, meningitis. So other than that, very good evidence is tubercular meningitis. But if you see the recent data in terms of meta-analysis and all, like steroid, like before antibiotic or with antibiotic, like we use 0.15 milligram per kg of the weight, 6th hourly for 4 days. So, like even recommendation is also not very strong. But we do practice like in terms of using like DEXA. Problem here is we go by the data. So strep pneumonia is the commonest agent. We assume, okay, once your diagnosis is meningitis, based on your clinical profile, even though you don't get the triad of meningitis many a times, it is not possible to get all the three picture, but clinical judgment is meningitis. So before or with the antibiotic, we use dexamethasone. But if it is turns to be TB meningitis, definitely we keep the dexa on.
Thank you.
The initial the people understood, okay, steroid which helps in increasing penetration of antibiotic into the brain. So that is not the rationality. So because it is an anti-inflammatory on the other end, so it reduces the inflammation and it will reduce the antibiotic penetration. We give steroid not for that reason. That we need to understand. The rationality is preventing long-term ototoxicity. Particularly data is more in pediatric age group and all.
So generalizations are always primitive. We should not generalize use of
Yeah.
steroids for all the meningitis.
Yeah, one question, Dr. Yash, to you and everyone. So, in ARDS, most of us are also always reading that you don't use muscle relaxants and all. So, how much we are able to do it? It's an open question to everyone. So,
I think it's only good on that paper which came out.
So,
Actually, I feel that we definitely start with sedation, fentanyl, propofol, fentanyl, midazolam, but we reach a point where there is a lot of ventilator patient dyssynchrony, and once you reach a certain point, you start getting hemodynamic instability. So in my practice, that is the point where I start using muscle relaxants. The point beyond which I feel sedation causes hemodynamic instability, because you would not like to have hypotension and then resultant hypoxia and that.
See, but if you see the data on muscle relaxant, so initial accuracy trial, fantastic outcome. So that is from the Papazian group, almost 1.5 to 2 decade back. So which in terms showed reduction in the mortality also. But when we got a rose petal group and all, which showed no benefit in terms of muscle relaxant. But the meta-analysis, systematic review, and the paper also, it suggests, okay, in the initial 48 hours, when we categorize according to our Berlin definition of moderate to severe category of the ARDS with a PF ratio somewhere less than 150, so it is okay to go ahead with muscle relaxant. There is no hardcore like contraindication even on paper also, even though whatever we got the report from rose petal study, but it is not totally don't use muscle relaxant. That is not the outcome. Definitely it helps in terms of synchrony. So when you prone, so we need to give muscle relaxant. Like even if you try to achieve when
So one interpretation of the rose trial could be it's
prone
quite
just
recent.
recruitment manner. So basically that helps in achieving that synchrony and all. So it is not like contraindication. We can still use.
Okay.
In this era, we are using ventilatory strategies much better than what used to be in the acurasis period. So, I mean, actually, why Rose didn't show much difference could have been due to actually.
Because so the categorization of the recruitment patients in Rose Petal was wrong. Because in terms of categorization, in terms of the PF ratio, and down the line, our lung protective strategy improved. We start by default from the day one only lung protective, irrespective of the ARDS. So many non-ventilatory strategies, supportive care, early recognition of the insult to the ARDS. If it is a pneumonia, we take care of with the antibiotic, early diagnosis. So keeping them U balance, negative balance, de-resuscitation. So many things came into the picture. So that's why rose petal per se doesn't show any sort of mortality benefit with muscle relaxant.
Yeah. So I think we're running out of time. So I'll thank all the panelists and request Dr. Shika to close the session with a few comments and a vote of thanks.
Well, Dr. Sunil, you've already summed it up. And I think this entire webinar, which was a joint collaboration between SNCC and ISCCM, has been a huge success in terms of covering two very important topics of critical care very broadly. And I congratulate all the speakers and the panelists. And I'm also thankful to Dr. Sunil and the chairpersons and Dr. Yash Javeri for all the smooth proceedings of this entire webinar. And there will be many questions, but it will always leave us with a desire to even learn more and prod even deeper into the intricacies of both these two topics. So thank you very much and have a good night, all of you.
Yeah. Thank you very much.
Thank you.
Thank you. Thank you, Dr. Yash, for inviting me. Thank you, everyone.
Thank you. Thank you.
Okay. Thank you, sir.